So hypersensitivity reaction is just a normal but exaggerated or uncontrolled immune response to an antigen that can produce inflammation, cell destruction, and tissue injury. So that's a normal reaction, but exaggerated reaction or exaggerated immune response, which can lead to inflammation, cell destruction, or tissue injury. So hypersensitivity can be classified as immediate hypersensitivity reaction, which is actually also called the antibody mediated reaction, but it can also be classified as delayed hypersensitivity reaction, which is normally cell mediated reaction. So these are the major two classes of hypersensitivity reactions. So, but the type of hypersensitivity reaction are 4 types, type 1 to 4, and we can have type 1, 2, and 3. They are antibody independent reactions, whereas type 4 is cell-mediated reaction. So type 1 is also what you call anaphylactic reaction, type 1 reaction, or type 1 hypersensitivity reaction, which can just range from life-threatening anaphylactic to milder manifestations associated with food allergies. So the main etiology of type 1 hypersensitivity, it is in case of atopic allergies. These are they are most naturally occurring, and the source of antigenic exposure is not always known, but of course this is normally familial or genetic tendency. So other agents that can cause this reaction include drugs, for example systemic penicillin, as well as insect stings. So, but of course there will be involvement of IgE or immune mediated IgE reaction. So in case of adverse food reaction, this can be fatal in most cases. So immunological activity in type 1 hypersensitivity involves mast cells or tissue basophils, which carry cellular receptors for immunoglobulin E, which attach to their outer surface, and their granules contain a complex heparin, histamine, as well as zinc ion. In this case now, there will be interaction of allergen, which will interact with membrane-bound immunoglobulin E, which leads to acute allergic reaction. So when, of course, molecules are released by mast cell when the allergen interacts with membrane-bound IgE. So IgE, it is always found on mast cell, excuse me, so as a membrane-bound antibody, which of course interact with antigen, and that is going to induce release of molecules from granules of the mast cells. So this what will happen, which is called, of course, degranulation of mast cells, where the IgE bounds mast cells with allergen, any allergen, which is going to cause changes into the mast cells and cause degranulation of molecules in the granules of the mast cells. So acute allergic reaction is that from the release of preformed mediators, for example, the allergy and asthma. So those mediators include histamine, leukotriene, as well as interleukin 4 and 13. So when there was close link of two IgE molecule, it is enough to initiate the mast cell release of the molecules. So anaphylactic reaction, which is also called anaphylaxis. Anaphylactic reaction is a clinical response to immunologic formation of fixation between a specific antigen and tissue fixing antibody, and this reaction is usually mediated by IgE antibody, and it occurs in the following 3 stages. So anaphylactic reaction occurs in the 3 stages, and this stage include that the offending antigen attached to the IgE fixed to the surface of mast cell or tissue basophil. And the second step, there will be activation of mast cells, which release various mediators. And the third step, the effects of mediators release from we produce vascular change and activation of platelets, eosinophils, neutrophils, as well as coagulation cascade. So anaphylactoid reaction, of course, in this case now, anaphylactoid reaction, it is clinically similar to anaphylaxis, but it can result in milder syndromes or milder manifestations comparing to the anaphylactic reactions. So it can result from immunological inert material that can activate serum and tissue protease and alternative pathway of the complement system. And anaphylactoid reaction are not mediated by antigen-antibody interaction. Instead, the offending substance will just act directly on the mast cell, which cause direct chemical release or degranulation and release of mediators or the tissue, such as anaphylatoxins of the complement cascade. So this is what will happen here. There is no need of allergen that must attach or that must bind onto the IgE immunoglobulin. There will just only be a certain substance that will act directly on the mast cell, which will cause direct chemical release or degranulation and the release of mediators. So this is anaphylactoid. So atopic reaction, it happens in some people with atopy. In case of exposure of the skin, nose, or airway to common airborne allergens, produces allergen-specific Ig antibodies. And T cell exhibit moderate proliferation and production of interferon gamma by type 1 helper cells, of course, and also cytokines produced by T2 cells, which include interleukin 4, 5, and 13. So this is just exposure of the skin, nose, or airway to any common airborne allergens. Those are common airborne allergens, which will then produce allergen-specific antibodies, and also production of some mediators, including interferon gamma, which is actually inflammatory mediator, as well as some other interleukins, the 4, 5, and 13. So this can lead to atopia because it is not really common in everyone, but there are some people with atopy who actually react to these common airborne allergens, and then it leads to hypersensitivity reaction in those patients. So symptoms, even though sometimes not everyone inhale airborne allergens, and everyone would inhale airborne allergens, but children and adults without atopy produce a symptomatic low-grade immunologic response. But if someone is with atopy, so the exposure will produce serious symptoms. Exposure to common airborne allergen will produce serious symptoms, including skin redness, sneezing, and wheezing within a very short time. And the localized reaction include it occurs in case of immediate response to mediators released from mast cells, and local reaction consists of urticaria and angioedema, whereas the localized reaction are severe but rarely fatal. So the skin reaction are characterized by appearance of redness and itching at the site of introduction of the allergen. This is what happens in case of localized reaction, of course, because this happens and appears at the site of introduction of the allergen. So in case of generalized reaction, it is because of the production of some mediators, including cytokines, vasoactive amines, for example, histamines from mast cell, and which leads to anaphylactic reaction. So atopic reaction can also lead to anaphylactic reaction, which is a very very rapid in onset and dramatic. Histamine leads to constriction of bronchial smooth muscle, edema of the trachea as well as larynx, and stimulation of smooth muscle in the GI tract which cause vomiting and diarrhea. And the resulting breakdown of cutaneous vascular integrity result in urticaria and angioedema as well. So vasodilation can cause also reduction of circulating blood volume and progressive fall in blood pressure, which leads to shock. So this is the effects of anaphylactic reaction, which is actually produced just from simple atopic reaction or atopy. And histamine has no effect on histamine release, and they are less effective in preventing bronchoconstriction in this case of anaphylactic reaction. In some cases also, some children who also suffer allergic disease, sometimes children with atopia also who experience a progressive allergic disease, which is called allergy match. And this is the formation of IgE antibody begins in early in life, but sensitization to food allergen like cow's milk manifested as colic or chronic otitis. It usually happens, and incidence, it is usually at the age of 2, but after 3 years of age, food sensitivity tends to decrease. And sensitization to inherent allergen typically can increase during preschool years, but in most children, of course, with asthma, it can begin anytime before 5 years of age. So this is in case of food allergen. Sometimes cow's milk. That sometimes young children would also experience allergic reaction to cow's milk, but it happens between 2 to 3 years of age. But also children who are really sensitive and food sensitive, they normally also still experience, and most commonly children with asthma, they still experience symptoms anytime before age of 5. So hypersensitivity reaction can be tested in laboratory, and first of all we have to obtain patient history and physical examination, which involves skin puncture test. And this can assist in the identification of foods that may provoke allergic reaction to these patients. So what we do, it is just to place a drop of solution containing a possible allergen on the skin, and a series of scratches or needle pricks are made and allows the solution to enter the skin. If the skin develops a red, raised, itchy area, this is a possible reaction, and then it means this patient is allergic to that particular food. So this is what we do, is just if you suspect, for example, someone is allergic to milk, for example, milk or any other kind of foods, you just prepare a solution of milk, and this is of course dropped on the skin, the solution on the skin, and you just scratch a series of scratches or just needle pricks on the skin, which allow some foods to penetrate the skin. And sometimes, and in some period of time, you are going to see the redness and raised itchy area, which of course indicates positive reaction of this hypersensitivity. But this is also a serious another problem because it carries serious risk, especially triggering systemic reaction. For example, you may just for example, someone is allergic to milk, for example, you may allow some fluids of milk to penetrate the skin of this patient, and this will provoke systemic reaction, because this person initially at the first place, the person is allergic to milk, and you are trying to introduce some milk in the skin. So this can lead to serious systemic hypersensitivity. So it should be you should actually be very careful with this test. So a patch test may also be used for evaluation of contact food allergens. This is about contact food allergen. So what you do, we prepare skin patch. Skin patch testing involves taping a patch that has been soaked in the allergen solution to the skin for up to 72 hours. So there's no involvement of scratching or needle pricks. It is just to place or to tap a patch that has been soaked in the food solution or allergic solution for up to 72 hours. Maybe you can just place it there and leave it there for some time. And so this is what you call contact food allergen testing. A patch test, it is contact allergen, because sometimes you know that sometimes patients experience allergic reaction just because of contact of some allergens. For example, someone is in certain environment, for example, or weather condition or anything. Maybe sometimes the person starts to develop like dermatitis, for example, or urticaria in that area. So or rash, right? So those can be a sign of allergic reaction, but that is of course contact allergic reaction. So we can use the patch test in order to examine possible allergen which could be causing that problem of contact dermatitis. The second type of hypersensitivity reaction, it is type 2 cytotoxic reaction. Type 2 cytotoxic reaction. So hypersensitivity type 2 and 3 are actually initiated by interaction between antibody but not IgE. So other types of antibody, for example IgG, it involves. So the distinction between type 2 and type 3, it is just based on where the complex of antibody antigen is formed. For example, that in type 2 reaction, the target is fixed in the tissues or on the cell surface, whereas in type 3 hypersensitivity, the target is antigen. Antigen is soluble and circulating immune complex are formed. So it means to distinguish between type 2 and type 3, it depends on where the target is located. For example, of course, where antigen is located. So if antigen is fixed on a tissue or a cell surface, this also, of course, it will also involve interaction of antigen with the antibody, but that is happening on a tissue or a cell, then it is type 2 reaction. Whereas type 3, there is just soluble antigen in plasma, for example, and then antibody is going to interact with antigen in plasma in soluble solution, and then the complex is formed in circulation, of course, in plasma. So 3 different mechanisms of type 2 reaction exist. The first mechanism is called antibody dependent complement mediated cytotoxic reaction. Antibody dependent complement mediated. So this is the first type of type 2 hypersensitivity reaction. Antibody dependent complement mediated cytotoxic reaction. So IgM and IgG bounds on cellular antigen activate complements and ultimately activate cytolysis. The first example and a classic example in this type is immediate transfusion reaction and immune hemolytic anemias. For example, hemolytic disease of the fetus and newborn. So these 2 situations or conditions are classic examples of antibody-dependent complement-mediated cytotoxic reaction. So this just means that antibody that is involving here is IgM, which is going to bind to the antigens on RBC, for example, after a certain transfusion of blood, or in case of hemolytic disease of the fetus and the newborn. IgM, of course, in HDFN, what is going to involve here is not IgM, but it is IgG. But we can just have example of IgM in case of transfusion reaction. So the IgM is going to bind on the antigen on RBC membrane. So which means this antigen is not a soluble antigen. This antigen is bound on RBC, on the red blood cell. So that's why this is classified in type 2 hypersensitivity reaction. So the second category of type 2 reaction, it is antibody-dependent cell-mediated. Antibody-dependent cell-mediated cytotoxicity. So I just want to mention something small on the first stage, which is or the first type of type 2, or the first class of type 2 reaction, which is complement-mediated. So complement-mediated, of course, even if antibody is going to bind the antigen, this cannot cause cytolysis immediately. So antibody is going to opsonize. We call it opsonization, or to mark that particular antigen on a certain cell. For this example is a red blood cell, isn't it? So then, because IgM can be able to activate complement, so it is going to destroy that particular cell that carries antigens. So that's what is called complement-mediated cytotoxic reaction. So the second is antibody-dependent cell-mediated. Here is no longer a complement-mediated. So what happens here? This depends on initial binding of specific antibody to a target cell surface antigen, and antibody-coated cells are raised by effector cells such as natural killer cells, as well as macrophage expressing Fc receptor. So target cell destruction occurs when cytotoxic substance comes in contact with these cells, and this is the mechanism of injury in antibody-mediated glomerulonephritis and many other diseases. So this is a very classic example, antibody-mediated glomerulonephritis. So in antibody-dependent cell-mediated cytotoxicity, there is no involvement of complements, but what's going to happen here is that antibody is going to bind on antigen, which is of course on a certain cell, for example, and what is going to happen is that there will be opsonization and recruitment of effector cells. Effector cells, for example, can say macrophage. Macrophage is effector cell as well as natural killer cell. It is also effector cell, and as you remember, natural killer cell or macrophage, they both express Fc receptors. And what is Fc receptors? It is a fragment characterizable of the antibody, that is Fc receptor, which is expressed on this effector cell, which is going to recognize antibody that has bound to the antigen on a certain cell. So then it is going to stimulate destruction of that particular cell that bears or that carries an antigen. So that is what we call antibody-dependent cell-mediated cytotoxicity. So the third category of type 2 hypersensitivity, it is called anti-receptor antibody. So antibody binds to a receptors of hormones in case of, for example, autoimmune hypersensitivity against solid tissues, as in autoimmune thyroid disease, which is or sometimes in hyperacute graft rejection. Graft rejection. So we are going to see this condition that we call hyperacute. Hyperacute is different from acute. We are going to see it. We are going to see this one in graft in tumor immunology, right? We are going to see tumor immunology in the coming days. We are going to see what is called hyperacute graft rejection. So now, this anti-receptor antibody, it is just a certain antibody that is going to bind to a certain hormone receptor. For example, in what you call autoimmune thyroid disease. This condition is also called Hashimoto disease, right? In Hashimoto disease, antibodies are going to bind to the receptors of hormones. And also in what you call Graves' disease, of course, Graves' disease is also a classic example here. Graves' disease, we could see some antibodies that are called TSHR. Those are the thyroid stimulating hormone receptor autoantibodies. Those autoantibodies are going to bind on the receptor that is designed for TSH, and that those receptors are going, those antibodies are going to stimulate receptors as if it is a TSH. So then this is going to lead to hypersecretion of hormones. So that is what we see in the Graves' disease. So Graves' disease is also autoimmune thyroid disease, which leads to hypersecretion of hormones because of those autoantibodies that stimulate receptors for thyroid stimulating hormone. So an example for antibody-dependent complement mediated, of course, we could see some of them. All of them are here: immediate or delayed hemolytic transfusion reactions, hemolytic disease of the fetus and newborn, autoimmune hemolytic anemia, and so on. So diagnostic evaluation of type 2 hypersensitivity includes, of course, you remember what we do in case we want to evaluate hemolytic disease of the fetus and newborn and hemolytic transfusion reaction. Of course, we have to type ABO, which is ABO blood grouping, resus testing, as well as screening for irregular antibodies using, of course, antibody identification panel, and sometimes titration of any antibody. So that's what we call titering of any antibody. So that's what we do, of course, in case of any hemolytic problem, in case of transfusion or hemolytic disease of the fetus and newborn. So, we can also perform DIT, direct antiglobulin testing, peripheral blood smear, bilirubin testing, and so on, and also flow cytometry and Kirchhoff-Bethke test. So we are going to see all the tests very soon. Type 3, it is what you call immune complex reaction. This is hypersensitivity, which is caused by deposition of immune complex in blood vessel walls or in tissues. So repeated antigen exposure leads to a sensitization with the production of insoluble antigen antibody complex. So this is a repeated antigen exposure. So this is a soluble antigen that is involved in type 3 hypersensitivity reaction. So as these complexes are deposited in tissues, the complement system is then activated, and macrophage and leukocytes are attracted and immune-mediated damage occurs. So this is actually what happens in glomerulonephritis, which affects, of course, kidneys, and also vasculitis. Vasculitis affects blood vessels. So in this case, there will be like continuous stimulation of immune system because of soluble antigens and production of specific soluble antibodies, which leads to formation of complex in blood, and then which is followed by deposition of those insoluble complex on, for example, on blood vessels, of course, sometimes, of course, blood vessels of kidneys, capillaries, right, which is going to cause allergic vasculitis, for example, and erythema nodosum. Sometimes also hypersensitivity pneumonitis is this category, and also sometimes serum sickness, which is normally seen in some conditions, and sometimes, of course, autoimmune disease like glomerulonephritis in systemic lupus erythematosus. We're also going to see how systemic lupus erythematosus also involves type 3 hypersensitivity reaction. It is actually type 3, even though, of course, sometimes it can also involve type 2, but most commonly systemic lupus erythematosus involves type 3 because there are very many soluble antigen that are going to bind with the auto antibodies, and then there's going to be deposition of complex insoluble complex on the kidney, glomerulus of the kidney, which leads to glomerulonephritis in systemic lupus. So these are some of the examples of type 3 hypersensitivity, which involves the reaction of soluble antigen and soluble antibodies resulting in the formation of insoluble antigen-antibody complex that are going to be deposited in certain tissues and cause or provoke serious damage of those tissues. Testing for type 3 hypersensitivity, of course, involves latex agglutination methods, nephelometry, as well as chemiluminescence techniques. So, in fact, fluorescent staining can also be performed on tissues biopsy specimen to observe deposition of immune complex in tissues. Sometimes other assays include quantitation of complements C3 and C4 in this situation. So that is type 3 hypersensitivity reaction, and the last type is type 4 hypersensitivity reaction, which is also called cell-mediated reaction. Cell-mediated reaction. So cell-mediated immunity is moderated by link between T lymphocytes and phagocytic cells, of course, monocytes or macrophages. So T cell, they don't recognize antigen, but they are immunologically active through direct cell-to-cell contacts by the production of soluble factors. So they have a capacity to interact with other cells, and they are able to produce soluble factors if they are provoked or stimulated by some of the mediators or effector cells like macrophages or monocytes. There are three characteristics of type 4 hypersensitivity reactions. Type 4 delayed type hypersensitivity reaction. Type 4 delayed type. Type 4 delayed type hypersensitivity reaction is also called DTH. So DTH involves antigen sensitized T lymphocytes or particles that remain phagocytized in macrophages and are encountered by previously activated T cell for a second or subsequent time. So here you can see that the problem here, it is re-exposure or second exposure or subsequent exposure to T lymphocytes because of some antigen or because of phagocytosed antigen or particles in macrophage or other phagocytes. Of course, macrophage is a classic phagocyte. So T cell will respond quickly and directly or by the release of lymphokines. So lymphokines, of course, those are the cytokines, like, for example, interleukins and interferons. So delayed hypersensitivity is a major mechanism of defense against intracellular pathogens, including mycobacteria, fungi, and certain parasites. For example, an example of mycobacteria, you can remember in Mycobacterium tuberculosis, as well as Mycobacterium avium complex, and many other mycobacterium, where you find, of course, granuloma formation or syncytial formation of the cells, especially, of course, macrophage. There will be release of mediators from T lymphocytes, especially T helper cells, are going to release mediators in order to try destroying those granuloma, or of course those syncytial cells. So this is what happened in Mycobacteria infection. So that is a type 4 delayed type hypersensitivity reaction, which normally involves second exposure or subsequent exposure because of a certain antigen or a particle that remain phagocytosed in macrophage. as example in the case of mycobacterium or fungi. Of course, you remember Histoplasma capsulatum. What it does, it is the same as Mycobacterium tuberculosis. The second type of characteristic of type 4 hypersensitivity reaction is rejection of foreign tissue grafts, elimination of tumor cell bearing new antigen. This is also another type of type 4 hypersensitivity reaction. So this is rejection of foreign tissue graft and also destruction of new antigen or tumor cells. So this is also another type 4. This is also cell mediated, but it is not a delayed one. It is not a delayed one, but because it is of course immediate, but of course always there should be also subsequent exposure here. But we are going to study tissue graft rejections in tumor immunology. It is also coming. It is a very nice topic, tumor immunology. So formation of chronic granulomas is also another type of type 4 hypersensitivity. And then finally, we are going to see how do we test for delayed hypersensitivity, or how do we test for type 4 hypersensitivity reaction. So a classic method of testing, or a classic procedure, is what we call skin test for TB, for example. We call it Mantoux test. This is a test of exposure to tuberculosis, and this is a classic example of delayed hypersensitivity reaction. So the test is based on the principle that soluble antigen from Mycobacterium tuberculosis induce a reaction in people who have acquired or have been exposed to TB or a related organism at some point. So it does not mean that the person has TB, but this person maybe have been exposed or have acquired TB at certain time, and in whether cured or whether the person still has TB, this test is going to be positive. So what is going to happen? We are going to take a small amount of antigen and we inject them under the skin, right, with a fine needle syringe. So the site of injection is then observed for at 48 to 72 hours for the presence of induration, which is of course like swelling or lesion. So then we could see, if we are able to see swelling of at least greater than or equal to 10 millimeter in diameter, that is going to give us a clue or idea that this person probably has TB or has been exposed to TB at a certain time. Other antigen that can be skin tested, of course, include diphtheroid, toxoid, tetanus, toxoid, fungal antigen, for example, trichophyton, histoplasmin, as well as candida, that use a patch test. You remember a patch test is just a skin test. So this is what happened. So for a patch test for candida, it is the same test that we use. We just have to apply a patch containing allergens on the skin in case of Candida albicans, and we observe or we check for redness of the skin or just tiny blisters that can develop after some time, over 48 hours, and then we report positive Candida albicans. So it means this person has Candida albicans or has been exposed to Candida albicans at certain time, right? So that is how we can deal with hypersensitivity reaction, and this is the end of our today's discussion about hypersensitivity reaction, which I hope that you enjoyed, and thank you so much for joining. And all right, thank you so much.